Good morning, friends and colleagues. My name is Dr. Keanu Shah. We have today with us Dr. Gregory Greenwood, my partner at the Extraction Academy and a faculty member as well. You would like to present our program, the mini residency series, and the three portions that come with the program, and go through this presentation and perhaps look at a couple of cases and discuss what we will be teaching at the Extraction Academy. A brief overview before we go to introductions. The Extraction Academy is a threefold system: an online portion where we do didactic and more case presentation type scenarios, and with a live workshop portion and a live surgical training in Mexico, which we are preparing for this summer. And you can take any of those three portions at your convenience and at different times. So the program details, we have an online series that focuses on anatomy, biophysics, pharmacology, IV sedation, medical emergencies, and surgical techniques, as well as postoperative care. And the workshops around the world, where we're going to 22 locations, we begin with introductions in history, some case presentations, and discussions about guided bone regeneration instruments. It's a lecture Dr. Greenwood will be doing as to proper usage, names, nomenclature, and also a hands-on portion on models and pig jaws, depending on the location we will be at, and another session of hands-on in the afternoon after the complications lecture and some case representations there, as well as our faculty passing down tips and tricks that they have learned, some of whom have been in this particular space, and they will pass on, and we will pass on the tips and tricks that we have learned over the years that will make your life as a clinician easier, and specifically for the extraction procedure. We also offer concierge services. The Academy will help our colleagues from around the world that wish to come and attend our one-day hands-on workshop, or even come and go to Mexico with us from San Diego. So I invite you to visit the website for more details on that. Very quickly, my name is Keanu Shah. Over the past 5 years, I've limited my clinical practice to oral surgery and implantology. I'm currently in the process of finishing up an MBA in international business, and have developed a great interest in implantology as a consequence of my interest in extractions, and I hope that you will consider the same. Dr. Wiedermann, an oral surgeon from Germany. We are an international organization. He has about over 20 years of experience, has had some education in the United States, an MD, a DDS, and a PhD. A very honorable man of service. And he will be helping us with some of the guided bone regeneration, as well as the complications lectures and the hands-on portions, as well as participate in the Mexico shoulder-to-shoulder surgery protocols that Dr. Greenwood will be leading.
I myself, Dr. Greenwood, started with pharmacology. I have a doctor of pharmacology, a PharmD, which I obtained in 1999. After obtaining my degree, I worked in the clinical hospital setting in pharmacy, specifically specializing in pain management. I furthered my education by attending dental school, then furthering my education with a mini residency in IV sedation, and extensive training at Harvard with extractions and implantology. I currently practice at the world-renowned Dental Implant Institute in Las Vegas, Nevada, and also head the clinical setting in Mexico for our live surgery course. Samuel Lee, our other partner, is a double doctorate He obtained his DDS from UCLA. After that, he obtained a doctorate in periodontology from Harvard University. He's a diplomat with the American Board of Oral Implantology. Dr. Samuel Lee concentrates on research and development. Also, he's the inventor of the Crestal window sinus kit and the sinus grafting technique. Dr. Samuel Lee practices in San Diego and focuses mostly on orthodontics, implantology, and extractions.
Excellent. Thank you, Dr. Greenwood. And last but not least, Dr. Charles Zahedi was a part-time faculty member at UCLA. Dr. Zahedi has traveled the world in educating thousands upon thousands periodontal students as well as dentists and implantology. He has a tremendous background specifically in Europe and North America. Interestingly, has founded the Oral Disability Rescue that caters to veterans as well as the elderly in fighting oral handicaps of edentialism, for which he is been granted some collaboration with the government, and he will be likely involved with us in mobilizing our colleagues to do some good around the communities in the United States. So, why did we put this academy together? What is it that we're trying to achieve? And I'm sure Dr. Greenwood will agree with me that at times the extraction procedure can become very, very stressful, especially if you don't have the right tools and knowledge to handle complications in the chair. Even though majority of your cases are pretty predictable from the x-rays and you will perform the procedure without any sort of complications, sometimes you get very surprised. Curvature of roots, irregularity in roots, ankylosis, on and on it goes. But the idea that a patient can sue a dentist for coming to a location to work and help the patient and remove a tooth for $9.8 million is not very kosher for us and our colleagues. So what can possibly cause this? When you see a lawsuit like that, you start thinking to yourself, what happened here? You have a patient that comes to an office, they don't get informed consent. The dentist attempts 3 different times to get the tooth out, and improper antibiotic regimen, improper referral. The referral individual does also not get an informed consent, and the patient develops chronic pain, is left out of work, and no one can figure out how to resolve this pain. Not the MDs, not the oral surgeons. So she is left with minimal amount of paid options, but to take action. So we want to prevent our colleagues from having to face this situation from very commonly done procedure by protecting themselves properly, learning all the things that we have learned with the mistakes that we have made, and save you those type of headaches. So when you establish a protocol for yourself and you follow certain guidelines that we will go over, you are really not going to be exposed to too much liability, but you're going to become a better clinician every time you perform the procedure, and you will learn every time you do the procedure without having to be afraid. So we want to help our colleagues to streamline their protocol and be successful accordingly.
Well, we start the Extraction Academy in a few short weeks. We start in Chicago, and in Chicago, we are going to have a really nice program, and that's going to be during the midwinter meeting. And after Chicago, we are going to go to a week-long meeting. It's called the IDS. It's in Cologne, Germany. We have a very special course set up there, and we will be there all week long to teach, answer questions, and even do some sightseeing with our students. Then, after Cologne, we're going to go to Copenhagen, and we're going to have a course setting there. And Copenhagen is very beautiful. I've been there several times. Following Copenhagen, we're going to stop off at Moscow. And in Moscow, we're going to do that during the dental salon. That's going to be specifically April 21st. And that's a very nice meeting if you're looking to visit Russia. If you've never been there, you can do some sightseeing and learn at the same time. Following Moscow, we are going to San Francisco. And in San Francisco, we're going to visit San Francisco during the AAO meeting. That's May 16th. And San Francisco is very beautiful. Following San Francisco, we also are going to stop in Shanghai. This is during the CDS, otherwise known as the China Dental Show. This is one of the largest dental shows in the world. It rivals IDS. And then, following China, we're going to stop in Berlin, and this is going to be during the ICOI. The dates on this is October 15th through 17th. Then, during Fachdental in September, we're going to stop again in Germany. We also visit the Expo Dental in beautiful Milan. That's in October in Italy. So I have a summary slide here, which I'm going to go through and list all the locations. Once again, in a few weeks, we're going to Chicago, then Cologne. In Atlanta, we're going to be there double time. We're going to do a show during the Australian dental meeting and also the Hinman dental meeting. Once again, Copenhagen was listed, Moscow, Anaheim during the CDA. We're also stopping in Vienna. Then we're going to visit several different cities. And we're going to wrap it up in November, once again at the Greater New York Dental Meeting.
For our friends and colleagues that are younger and out of school and may not have the liquidity to register for this class, we have put a program together also as a financing option, which is to be able to enable them to register and work with us, as the ROI is phenomenal. This is one of the most lucrative dental procedures for a dental setting, and this investment will help you become a better clinician in terms of your knowledge in the extraction procedure. So that opportunity is also available for those that wish to attend but don't have the means to do so. Thank you, Dr. Greenwood, for a thorough overview of our tour around the world and working with our colleagues and learning from another. At this time, we would like to perhaps move into some case presentations and discuss some techniques that we use and some instruments that are newer in the market, and discuss those. We don't particularly support any instrument. We teach all instruments, the pros and cons of them, and what we believe will best benefit our colleagues. So here we have a two-stage full mouth extractions, full over full, immediates. A common procedure for the GP that is dealing with gross periodontal disease. As you will see, the generalized stage 3 and stage 4 and pockets of in excess of 15-20 millimeters that are not really in a position to be saved. You know, you can have the periodontous packed bone and hope to get clinical attachment loss, but a clinical attachment gain. But in this scenario, you have excessive bone loss, and the patient has decided that they wish to move forward with full over full coverage and in an immediate scenario. So after anesthetic and doing all the preclinical preparations that we will discuss at the academy, we are going to be focusing on levers and fulcrums and motions with apical grip forceps, for instance, in this scenario, versus some of the instruments that utilize different fulcrum, such as the fulcrum forceps and others alike that are coming in the marketplace. There is no particular one instrument that solves it all. You have to be familiar with the force scenario. And in this case, you saw how we broke off the mesial root in the process of extraction. And at the academy, we will focus on discussing trephination, flaps, removal of smaller roots. In this case, you have an older patient that has pretty strong connection between the teeth and the ostium, and at times you will encounter what might appear as a very easy extraction, where you're left with 2-3 millimeters of a root, and you have to go after it, and you have to make a decision. You can see that in this case as well, as to how you're going to recover the rest of it, and if you are going to recover. Dr. Greenwood is very exact. He likes to always get everything out. I sometimes, when I have less than 2 millimeters, especially in a wisdom tooth scenario, I my personal preference is to leave it. I get a little disconcerted about the area, but again, it will depend on your clinical knowledge and your preference. In this scenario, we saw three instrument concepts where we get our pop phenomena, and we break the periodontal ligament from the ostium and utilize forceps to remove the tooth. Also elevation and concepts such as your mesial buccal being your safe zone will be discussed for just about all your teeth. Here we have a follow-up. Posteriors have been extracted, the anteriors we left for aesthetic purposes. And when you have a scenario where you are removing all of the teeth, you can utilize your adjacent teeth for elevation purposes. And when you do these luxation motions, you have to consider that normally if you're doing a single tooth or multiple teeth on one side, your goal is not to utilize the tooth, and that's sometimes very hard to do. So you have to find a good purchasing point that makes a compromise between you not affecting the tooth at all versus you pushing a tooth. And if you have a crown there, you likely may end up removing the crown that you will have to cement. But in this case, we want to work clean. We want to get our papilla and to separate it. Then we want to do an elevation motion, get the freeze the soft tissue and the attached gingiva away from the tooth, so we can play the one important game that is called how do I weaken the root the most, and extract the tooth accordingly. Sometimes freestanding canines, long roots, extremely hard. You should anticipate that you may have to use the handpiece, especially if you have extremely long root and solid bone, and it's an endo situation where the patient simply wants the tooth out rather than doing restorative work. So here, sometimes you will stop and naturally administer more anesthetic. And you have to be very careful with fractures when you're dealing with single teeth. You don't have that adjacent bone to dissipate some of the forces. You will need to worry about fractures, anterior, posterior, especially in the lower third molars. Here, with a single rooted teeth, you can do rotational movements as you would do in a periodontic tooth, and it's a shear force of separating the tooth. The shear force and a pop sound, which we call the pop phenomenon, are very important to know at what stage you are in intra-procedure. So here we took a little bit of the buccal bone. That's okay. You're not planning to do implants. If she wanted to have implants done as a means of securing her prosthetic even further, we would reconsider our position in the loss of that buccal bone and perform guided bone regeneration. In this case, the patient did not wish to do any of those things, and wanted to simply have the appliances. So here we go. Rotational movement, very slow. It's an art. It's a perceptual ability. It's a feel that you get when you're doing the extraction as to how far you can push it before that tooth breaks. So back and forth motion buccolingually, and if you don't have adjacent teeth, you can also do mesiodistal luxation. Very well. So this is our immediate, as an example of an immediate case, but we'll be going over many others at the academy. Um, For up to teeth, a lot of times you see this, and there is no reason, in my opinion, that a GP that has a little experience in extractions and is comfortable can not tackle this simple case. You have maybe some soft tissue impaction, not a big deal. We'll discuss those. But the simple cases where you're looking at the Panorex, or even better if you had a CT scan, and you see that you're far away from the tooth, and your Panorex is somewhat calibrated, that you're a distance away from the superior border of the inferior alveolar nerve canal and the bundle, that you are in a pretty safe zone, unless the tooth breaks and you have curvatures and you have interradicular septa that will make your procedures harder. So this is a simple case. We should be able to tackle it. These roll right out if purchased in the wrong space. And the lowers buccolingual motions will also be a productive way. All right, Dr. Greenwood, please.
Yes, here we have we're actually demonstrating the four um, soft tissue slash surgical wisdom tooth case, and for the uppers, I really like to make a purchase point, and if you get the right spot at the right angle with the right degree of curvature, you can really just get in there and pop that upper one out. Now for the lower wisdom tooth, it's a little bit of a different story because the bone is a little bit thicker. So you really have to judge it carefully and be careful where, sometimes you have to trough, sometimes you don't. But once again, this is an art form. With the correct technique, which you will be taught at the Extraction Academy, you can make these as I call a simple elevation case. All you need is a straight elevator. And as directed here, we're going back up top to the maxillary wisdom tooth. We got a really good 45-degree angle with a good purchase, and we essentially roll it right out. Patient does not experience any pain because we have profound anesthesia. Then, once again, for the last one, we're able to elevate the mandibular third molar out of the socket very cleanly, root intact, and all we do is simply place gauze. This is a high profit, low cost procedure. We can
So
also
a lone
view
standing canine back. Go ahead, please.
we can also view the lone standing canine here. In this case, you really have
So
to
the
be
lone
careful
standing canine that
because
we were discussing rarely will come out. So here we have the maxillary immediate using elevators, power elevator, and a forceps. And we will discuss briefly on how to do this procedure. Dr. Greenwood?
yes, for this one, we simply elevate, and with the lone standing molar, we have to be careful because we can really have some complications here. But for the anterior periodontal involved teeth, we simply elevate to create some movement and to tear the PDL ligament. Once we've torn the PDL ligament, um, we can actually get in there with a forceps and complete the delivery of the tooth. As you can see, we're delivering the anterior teeth with a simple twist motion. And all you do is go ahead and twist with the forceps, and the tooth can be delivered essentially atraumatically. Now, as we move posteriorly, such as in the canine area and further back, we really have to be careful for breaking the buccal plate. For the maxillary lone molar, we have possible sinus complications. We can tear the sinus. Even in the premolar area, we have to be careful of our anatomy. Once we get to the canine, we save that last because usually it's the most difficult tooth to remove in the maxillary arch. It's the cornerstone of the mouth. And once again, as you can see here, for periodontally involved teeth, we can simply elevate and deliver with a forceps. But we must be careful of the lone standing maxillary molar. Upon delivering the prosthesis, a pertinent medical history is obviously advantageous. We have to be aware whether the patient's on blood thinners or not, and we have to take adequate, proper steps to control hemostasis. Again here, we have the maxillary lone molar, and then we're delivering the prosthesis.
Maxillary erupted third molars. Very simple scenario unless they lie horizontally toward you and underneath the tooth, which makes it quite complicated to find the tooth. But a lot of the times, and you will see that in this demonstration here, you will see the tooth lying what would appear from the visual angle that it lies buccal to the second molar. And trying to engage your tooth on the mesial aspect and working yourself distally has been very easy because you can predict where the location is and it will roll right out. You're talking about D4 or D5 bone in the posterior maxillary region, which means that your bone is not the issue. And at times you're going to take the tuberosity if there is some ankylosing, which is not that big of a deal. But if you remember, Dr. Greenwood said that you could have sinus complications. This tooth might, for example, this endodontically treated tooth might already be in the sinus. The only thing separating it from the sinus being the Schneiderian membrane. And when you take the tooth out, you have exposure. So we have to discuss on how to plug up and allow for healing of the Schneiderian membrane, which is a very highly vasculated layer of tissue, very highly, perhaps one of the most highly vasculated. So it heals fast, but you have to do certain things. You have to make sure that you have your collagen membrane, your plug, or whatever technique you're using with your figure eight suturing or vertical mattress, that you get primary closure, because once you start getting food up there and other things, it's going to be a problem for you. We will discuss thoroughly how to do these more simpler cases, and sometimes you come in here on the mesiobuccal and you don't find your tooth because it's laying lingually, and that gets pretty complicated. Now you have space issues. You may have to come in from the lingual angle. You got greater palatine nerve arteries. You have to pay attention to anatomy very closely again if you're going to take that approach. So you will discuss these type of cases that will benefit you in your practice. You know, depending on what you bill out for this type of procedure. It used to be fun to do in between larger cases. When you get really, really good at them and you bring the patient in, you follow your protocol, you go through your medical, you do every single step. It's a very speedy protocol, and as Dr. Greenwood has mentioned, very lucrative at that without any laboratory fees and some minor instruments set up. Here we are looking at one of those simple cases that will take you 1 or 2 motions to get a break from the mesial. There's all kinds of instruments you can use for the purpose of demonstration of a curve luxator, we've used this particular instrument. Notice how we place the Minnesota and push against the distal area. We don't know if we don't have full visibility on that maxillary. We have an idea in our head where the mesial is and where we're going to engage. And to go back to this, as this is an important point, you have the placement of this will prevent that tooth from rolling back in no man's land, not in the sinus, and there's a space behind this tooth where we sometimes lose the tooth and ask the oral surgeon to go look for it. It doesn't have to happen to you if you indeed protect that area and make sure that if force is applied, that the tooth will rotate out against the Minnesota. So not giving it a chance to disappear where you don't want it to be. So here is canine, and we were unable to remove the tooth at once and without breaking it. So we will discuss troughing procedures, laying flaps, and getting the tooth out, hopefully in one piece. And if you have an endodontic situation, it becomes a bigger issue than a simple root removal. You may have to do it a few times.
Okay, we further discussed the retained premolar root. And as you can see here, the premolar, most of the clinical crown is decayed. And these cases can be very challenging. Then we also have the retained maxillary third molar root, where the clinical crown is once again decayed, and you essentially have to go and remove the remaining root tip. And those can also be challenging because you're essentially working in, as Dr. Shaw said, a blind spot and around the corner. So we definitely have different techniques and tips and tricks to make these, once again, in between your major cases. You can schedule these as they walk in your office for same day definitive treatment. You don't have to refer them. You don't have to prescribe antibiotics and pain meds and reschedule them. We'll show you how it's done very simply, very effectively. And as you can see here, move down to the mandibular area, and another wisdom tooth case where we elevate and we place our purchase point right on the mesial buccal for a nice release, and we're able to deliver the tooth atraumatically with root intact. Patient is very comfortable. Once again, you can always add IV sedation to your regimen when removing wisdom teeth, regular teeth, or broken down root tips.
Oh, very good, Doc. In that, the same notion, when you do have these mandibular molars, the last one that Dr. Greenwood discussed was fairly straightforward, but sometimes you will have cases where you have extreme root curvature. And in this case, by the way, this is exactly what you don't want, is this type of a radiograph. If this radiograph was indeed true, it would be silly to take a tooth out in this scenario without a CT scan study. You do not know if this mandibular nerve is really going between the roots. Is it going adjacent to the buccal root? Is it going lingual to the lingual root? You have no idea. This X-ray is non-diagnostic. However, with a CT scan, you will be able to locate these. And then when you do the extraction, if you have diverging roots that each have a 90-degree angle to them, you can expect that you're not going to get this out in one piece. So then the question becomes, do I go after this other second piece, and what is the consequence if I don't? And those things will be discussed at the academy. But this is for illustration of what an assistant might deliver for you as a consequence of you ordering an x-ray. But that doesn't mean that you should settle for this. This is not the proper angulation. It's very deceiving, but yet, indeed, the tooth was close to the mandibular nerve, but not in this relationship. So a two-dimensional photo is not always going to help you. It will help you if you calibrate and you use certain techniques there, and we will visit those at the academy, where we will also discuss some CT scanning. It would be a good idea for those of you that are not in the implantology world yet to utilize the academy to start becoming familiar with how to read CT scans, how to do the simple things that are so accurate now, that you will be able to expand your practice into yet another very easy procedure once you gain the main concepts of oral implantology. The world is changing, guys. You know, back in the day, in the 70s and 80s, we take a tooth out and nobody worried about what to do. And okay, maybe down the road we'll do a bridge here. And if it's a distal extension, well, it's going to atrophy. And that's where we are. Today, the school of thought is changing. And every time we do an extraction, we think to ourselves, are we going to place something there in the future? Is it going to be a partial denture? When we do a tooth where we have two adjacent version teeth, and I must tell you that standards of care have changed. You cannot do a bridge on two adjacent teeth that are version teeth and have a clear conscience if you didn't explain to the patient, hey, you have an option here for an implant. And learning implants, you have, in order to do implants, you have to know the extraction procedure. Because, for example, when you do an immediate implant, the majority of your time is spent, probably 80% or more of the work is spent in the nice and cleanliness of the work that you do throughout your extraction, which will determine if you will be placing that implant or not. If you don't have three walls, you take that tooth out, there's no need to even try to put an implant in there because it won't be as accurate as you want it to be. So the best thing is to do guided bone generation, come back in a few months and place the implant. So that the thought has changed. Now we don't do just extract the tooth, get primary closure, do a bridge later. You worry about that bridge. You're going to want to put bone in there. You know, I always offer it where I believe it's indicated to do bone grafting. So the ideology is changing, and we must move with the times, and we must learn the most up-to-date thing that's available in the market.
Okay, very good points we're presenting today, and I'd like to discuss a little bit about impacted maxillary thirds and partial bony impacted thirds that are mesioangular. Once again here, we're starting in the maxilla. We have a nice 45-degree angle and a mesial buccal purchase point. We're elevating against the bone and the second molar, and we are able to slightly elevate the tooth out with no problem. For the lower, what I like to do is a buccal hockey stick. Then we make a buccal trough. Once the trough is made with a mesial tilt on it, we're able to get the elevator in our sweet spot, move the tooth, and rotate it distally for a nice, clean delivery with the root intact. If we break the root off, we have techniques that we will teach you to be able to go in there and atraumatically clean it out. Once again, up top, we're able to elevate the tooth, and the patient, in this case, was not sedated, did not experience any pain, and healed beautifully. With our post-op protocol, we'll give you ideas, time-tested methods that we've done to have an uneventful post-op healing period with the use of pharmacology and proper oral and written instructions.
Excellent. Yes, we would love to learn from you, Dr. Greenwood, on the IV sedation front. I think that would be a tremendous benefit for our colleagues. And here is you're looking at a CT scan scenario. If you're going to see this tooth right here, and you know it lays on top of the nerve in your canal, at the very apex and along the apex line, a horizontal section, you might want to consider, just like anything else, proper treatment planning before you go in. This is an art, but it requires some prior work. I spoke briefly about calibration of your x-rays here. You know, you could, and many times what implantologists do is they use a ball, a metal ball, and they know the measurements of the metal ball and accordingly compare it and make the calculations for calibration. In this case, we want to go after this tooth for an elderly patient. You would not consider it, as in this case, where there's no issues, but this patient started developing great decay on number 31, and you know, then you have to make a decision. Do I want to lose both of these teeth? You don't like doing implants in second molar areas. There's so much complications. But what if you have to? Sometimes you do. In this scenario, it was a decision to remove that tooth and preserve the future health of this tooth and its prognosis. So at the academy, what we want to do is we want to go through step by step of what happens. Make an incision. We have our retromolar triangle. We want to stay away from, as we make our incision through the retromolar triangle, we want to go distally and up to stay away from this nerve that comes down here, as well as the lingual nerve that varies for everyone in terms of anatomy. Sometimes it lies here, sometimes it lies a little bit lower, and we'll go through those slides, anatomy slides, with you in describing those relationships. The simple things that could really turn into something ugly if you don't know. If you make an incision here and you catch the lingual nerve, then you're looking at a microsurgeon having to suture that nerve back together and crossing your finger hoping you have full recovery. We will go through those complications with you at the course. We will discuss the different methods of point discrimination, things that you have to do if you get into this type of a scenario where you have damage that you've seen and know that has been done to the nerve, or as a consequence of the follow-up appointment of complaints of paresthesia, taste sensation, and so forth. So here, you know, after the incision, we do the periosteal elevator, which is one of my favorites. I think it's a favorite of many, where we remove the thick fibromucosa for a full thickness periosteal flap. Once we obtain our full thickness periosteal flap, we always want to get a visibility as much as we can, preferably 360 degrees off the tooth itself. Then we have to determine, do I need to cut any impedance to get what you would refer to here as a common path of draw, or do I need to literally section the tooth in 2, 3, 4 pieces in order to strategically get it out while I keep in mind my vascular bundles and other anatomical landmarks in the area. So in this case, we were able to gently remove with a high-speed burr, and this takes a lot of good manual dexterity. You know, people that like endodontics, right here, you have to be very accurate and you have to be very, very stable in your support that you use. By removing that mesial impedance, we are able to create a common path of draw, simple elevation method. Bone usually gives, and depending on the age and multiple other factors, you will start developing a feel of what you can and cannot get away with when you do these type of surgeries. I was able to get this tooth out without any kind of issue by simply removing the mesial and elevating it out. Some oral surgeons and other doctors would prefer to trough the entire buccal right off the bat, separate the crown, get full visibility on the root, and go into the furcation, separate the furcation, take one of the T2 out that make more strategically sense first, and then go after the last piece in a three-way scenario. And everybody's going to do it differently. And usually once you get in there and you've done all your studies and you've looked at all the x-rays and you've done everything by the book, you'll realize that, hey, the x-rays aren't telling me the entire truth. I must readjust my surgical technique right now and right here. Thank you very much for attending. Have a great day, guys.